This is the second so-called wave of COVID-19, and we're clearly better prepared for it, and we have more information about the virus and its potential implications on our patients and beyond. We at the Brompton and Sheffield NHS Trust were very proud to be part of a national effort to combat the first wave. Back in March, we were made over a night or two a COVID center. This time round, as I said, we are better prepared. And while we still provide for the extreme end of the spectrum of patients with COVID, both hospitals are operational, and we are here to provide for our patients, our adult congenital heart disease patients. There is anecdotal positive experience about the impact of the virus on ACHD, both from us and other centers. And in general, our patients weather this infection, if exposed to COVID, well. This is a slide that you will hear elements of it in the presentations to follow. From early March, that we had another webinar with the support of Live Media and the Samuel Foundation and the Greek Cardiac Society. And what this advice is that out of this moment of difficulty, if not crisis, how can we make good things? And how can we look in what we want to learn out of it, and how can we better take better care of ourselves? And there are many ways of achieving this. We've seen also the application of technology, and I'll touch upon some measurable benefits out of this crisis for the care that we provide for the patients, and also for the direction of travel. Take better care of ourselves, look after our diet, exercise regularly, optimize our weight, give up smoking. All these are good things, things that make us stronger even against the possible COVID infection. Many elements of the discussion in this 1 hour platform are covered in this paper, which is published in the new International Journal of Cardiology, Congenital Heart Disease, launched in the midst of the pandemic. It's free access to this paper. Have a look at it. Also consider your work and experiences submitted to it. This is the direction of travel of us, of having patients with congenital heart disease. All patients with congenital heart disease assessed in the middle of this busy slide on a single busy day, their condition, their direction of travel, what they need to know, how they can plan their lives, and all this downloaded on their mobile, so they are better aware about it. They can be more independent. They can plan their lives, and depending on whether they are high risk or low risk, have individualized follow-up. This is investment that the Trust is making, and this is the imaging center, which will be opening in December 2021, so it's just a year from now, where we'll be housing much of this core ACHD activity. And one of the presenters, Eileen Heng, will be discussing in greater detail this other opportunity, again, with technology and application, with the support of the Trust and working closely with HUMA, a number of us, that we're about to launch in a pilot study of remote monitoring of the patients, ultimately leading to self-patient management. And a lot of information on our site about educating and empowering the ACHD patient. So this is my introductory short presentation, and I've just stopped sharing, and delighted to introduce the next speaker, who is Professor Gerhard Diller, who has a main base in Munster. Gerhard is the academic leader of the large ACHD and very active program there, and has a relationship with us, and also under the larger umbrella of our partnership with St. Thomas's and King's College. So he's a visiting professor at King's College here in London, and also the president of the working group of the European Society of Cardiology for Congenital Heart Disease. And he will be presenting for us a position paper from that group that is coming out in the European Heart Journal very soon. Gerhard, thank you for joining us today.
Thank you very much for this introduction and for inviting me to this online seminar, online discussion forum. It's a pleasure and an honor to share with you some thoughts on the topic that unfortunately has again become quite relevant to all of us across the continent, with the second wave of COVID emerging in many countries. So I will just start sharing my screen. All right. So my presentation basically deals with some recommendations that are emerging under the umbrella of the ESC Working Group for Adults with Congenital Heart Disease in cooperation with the International Society for Adults with Congenital Heart Disease, mostly based in North America, as part of a position paper. It's mostly based on expert opinion, I must say. Unfortunately, there is still, to this date, very limited data specifically for COVID-19 and ACHD patients. We are constantly learning, but there is little solid data. So there is, it's mostly expert opinion and extrapolating from other types of data. Of course, healthcare professionals and patients themselves are understandably concerned with this epidemic or pandemic and what impact COVID may have on their health and which risks it may bring with it. We know from other conditions that other viral infections, that of the most viral infections that affect primarily the lungs and cause viral pneumonia, quite commonly also have an impact on the heart and the cardiac system, and may lead to cardiac complications. This is some data, just to give you a very brief background, that is based on administrative data from a large health insurance, where we specifically looked at the risk of adverse events and death, among other issues, in patients with congenital heart disease who were hospitalized for viral pneumonia and had a main diagnosis of viral pneumonia. So this is a study before the onset of COVID-19. There's other types of viruses, mainly the flu, so influenza viruses. But what it clearly shows is that the fear and the caution that we are experiences is quite relevant, and there is a basis for that. The study basically shows that ACHD patients who were hospitalized for viral pneumonia as a main diagnosis had a relatively high rate of adverse outcomes that was comparable to older individuals without congenital heart disease. So despite being much younger on average, these patients had a high risk of complications. So it basically gives a rationale for putting ACHD patients in a rather higher risk group when we speak about viral disease in this population. But as I said, this is not specifically COVID. This is other types of viruses, just a background to the discussion that we're having. More recently, the ESC Working Group for Congenital Heart Disease, as I said, together with the ISAC, came up with some recommendations on how we see the risk and the management of adults with congenital heart disease in this pandemic. And what we came up with is this expert recommendation. As I said before, recognize that viral pneumonia also has an impact on the cardiac system and may be associated with heart failure and other heart-related complications. And of course, we know from various studies across the globe that there are general risk factors for adverse outcomes in patients with COVID-19, such as male gender, older age, obesity, and some other comorbidities. But the question comes down is what are the specific risk factors for adults with congenital heart disease? And I think the important message that we want to give from our expert discussions is that anatomy in itself is not sufficient to guide risk stratification. Of course, it forms a basis for discussion, looking at the underlying heart defect, whether it's a rather simple defect or a more complicated heart defect like a univentricular heart, will be relevant to discussion. But it's also important to look at many other factors like the heart function, previous arrhythmias, the blood pressure in the lungs, the presence of cyanosis and other complications. So you have to see the whole picture of anatomy and physiology. And we need an individual assessment of patients with congenital heart disease. And this comes down to an interaction with an expert in adult congenital heart disease to guide patients into which risk category they may fall. But based on this anatomic and physiologic classifications, we came up with these three proposed risk groups: low risk, moderate risk, and high risk. And then once patients are stratified into these risk groups, the question is what recommendations we would give. And again, I think it quite clearly emerged from the discussions that it's not really about paternalistically telling the patients what to do. It's about guiding patients and guiding colleagues what recommendations we should make. And of course, there are many factors that need to be taken into consideration that will affect what we recommend to patients. Of course, every patient must follow the usual protection measures, such as face mask and social distancing. But it really depends on the risk group for ACHD patients, how to manage patients, both to prevent COVID-19 or SARS-CoV-2, and in case of a confirmed virus infection. Most patients with low risk profile it will be possible to manage them at home with remote monitoring, whereas the most complex high-risk patients need to be admitted for the most part and be under medical surveillance. And then for the moderate risk ACHD groups, it also depends on their profession, on their contact to public and clients and students and colleagues and so on, and how various protective measurements may be used to reduce the risk of COVID infections. But as I said, it's an individual discussion with patients based on this general principles that we try to establish to guide patients. And the last thing that we recommended in this papers is that to have a very proactive approach to patients with congenital heart disease, to have a low threshold to test for SARS-CoV-2 in these patients using a swab test. If patients are unstable or considered to be higher risk, there should be a lower threshold for hospital admission. And our patients, I think, need a higher level of rhythm monitoring and proactive cardiac care compared to many other cardiovascular patients. It's also always a good idea to early involve ACHD specialists in the care of ACHD patients, to plan advanced treatment and discuss ITU treatment. And of course, it's all comes down to a multidisciplinary treatment in this complex situations. So I think the principles are largely similar to what we use in non-congenital patients, but the focus should be to be more proactive, to be more attentive to potential complications, and to involve specialists early on in the care of patients with congenital heart disease. So this is the conclusion of what I wanted to present regarding these recommendations. Of course, ACHD patients are a growing and complex population that requires protection from SARS-CoV-2. And as I said, a proactive, tailored treatment approach is warranted in this condition. There is a great anatomic and pathophysiologic heterogeneity in our population, so an individualized approach is really warranted in ACHD patients. On the positive side, patients with congenital heart disease are typically younger and therefore may not uniformly fall into a high-risk category, such as many of the other older patients with acquired cardiovascular disease. And importantly, risk stratification is not easy in this population. It requires expert input, and it requires a good understanding of physiology, anatomy, previous clinical status, symptoms, and so on. And it should also take into account the psychosocial profile of the patients. And we don't want to advocate uncritical social isolation in this in patients with congenital heart disease to avoid psychological distress and avoid negative impact on the patient's life. So I think again, just to boil it down, I think an individual decision is required. Expert opinion should be thought, and all the recommendations need to be arrived at in discussion and in interaction with the patients. Thank you very much.
Thank you, Gerhard. A lot of information and food for thought, I'm sure, will be discussed at the larger panel part of the session. We are moving now to the next speaker, who is Dr. Natalie Chung, who is the clinical lead of ACHD at St. Thomas's. And Natalie, with myself and our teams, have been working the last couple of years towards the partnership between the two institutions and all the opportunities ahead. Natalie will give us the UK scene and perspective to this. Thank you, Natalie.
Thank you, Michael. And welcome everybody to the webinar. It seems that there is a very large number of patients and interested colleagues that have joined us today. I haven't done any slides per se. My information today is very much guided towards informing patients about what has been happening in the background, some of which you may not be aware of. So as you know, COVID, the first wave, struck in March and into April and May. And as a group of ACHD clinicians and services across the country, we started to work together from a very early point in this. And something that patients may not be aware is that there were weekly meetings which started on the 20th of March and happened on a regular basis into May, gradually tailing down to monthly meetings. And each service and network of ACHD clinicians is meeting from across England and in Wales and Scotland to share with each other what has been happening around the country in terms of the activity and COVID levels and how different services have been coping. And as part of that, we've been very much sharing individual service practice to try and help each other, to share new ways of working, what seems to be working well and what has not been working as well. And the other point about the UK services working together is that potentially we are there to help each other in the need of geographical demand. So at the moment, we know that the COVID activity is much worse in the northeast and northwest than it is down in South England. And by speaking to each other on a regular basis, we can help to give each other support, and if needed, provide services for patients who wouldn't normally be included in our geography. The good news, though, I think, is that the COVID has produced some positive changes to practice in the long run. You will all, I'm sure, have experienced a change to virtual consultations and clinic appointments by telephone and video. Now, whilst we fully appreciate that that's not always going to be the best way to follow up patients in the long run for every single assessment that they require, it has proved to be very useful in certain situations, and the general feedback that various services have had from their patients on the whole is that they have found them useful. They've definitely, in some situations, a very good way of providing a tool for patients to ask services about certain concerns or queries, and also as a way for us to provide education to patients on an individual basis. The other thing is that adult congenital heart disease is often neglected within the very large world of adult cardiology and cardiovascular services. But one thing that COVID has done is highlighted to all of our colleagues the importance of diagnostic testing and access to non-invasive diagnostic testing, and in particular echo around the country. And certainly for our service, we've got a bonus. It's been a bonus that we've been able to establish additional dedicated adult congenital heart disease outpatient echo lists. And I think there are some other services around the country that have also had very good support from their cardiology colleagues in being able to change services in the long run, but also in particular to deal with the backlog of imaging that we all know has built up over the last 6 months when patients were unable to travel into hospital to have their echoes and scans. And that I've only got a 5-minute slot here. There's so much I could say, but I think the last thing that I just wanted to point out is that there are other ways in which we've changed our working. So, for example, we are now sending out 24-hour tapes and monitors to patients, such as overnight oxygen monitoring systems, so that they're posted out to patients with explanations on how to use them, and they can be posted back. So there is, another way of changing the flows and helping patients reduce the number of times they need to visit hospitals. And those sorts of initiatives are being supported by YouTube videos to help patients explain how to use equipment if it is being sent out to them. So I just want to finish off my slot finally by thanking the patients and their families and carers for your patience and your understanding and appreciating that the clinicians, colleagues that I work with, and that at the Brompton and across the country, both doctors, nurses, physiologists, we've all been working very hard to try and provide as much of a service as we can to you, and to absolutely make sure that if there is any emergency or urgent care that needs to be done, then that is undertaken. And I know it can sometimes be frustrating when we can't always get as much information to you as we would like in a very timely manner, but we do appreciate your understanding in that. And I'd also just like to take the opportunity on behalf of all of my colleagues to thank all of those patients and families that have actually contacted us spontaneously to check that we, as your clinicians and nurses and teams looking after you, that we are actually being okay as well. And that's been very much appreciated too. So to conclude, although we are into the second wave, I can reassure you that services across the UK are working together and communicating on a regular basis, and we are helping to share with each other the positive things that will come out of the COVID experience and that we can incorporate into the longer term care for our patients. Back to you, Michael.
Thanks a lot, Natalie, with a wonderful and positive message, as it should be. And we'll talk about more opportunities out of this challenging situation. So just to mention to our large audience that although we have a lot of questions, a depository of them that you've kindly sent to us, you can still send us questions on the private chat, and I'll try to deal with them after the presentation. So the next presenter is Alex Kempney, who's a consultant colleague and the lead of our SCSD catheter interventional program. And he will briefly talk to us about how was it possible, with us being a COVID center during the pandemic, to provide for the patients and interventions. Alex, off to you. Thank you.
Yeah, thank you very much for allowing me to present. And the presentation will be quite short and focus really on this slide. And what it shows, the bars present the percentage of activity compared to the normal activity observed month by month. So the year started obviously very happily. In January and February, we were doing 100% of the expected volume of procedures, and then obviously by the end of March, things changed very rapidly. And with the announcement of lockdown and also the huge surge of patients with COVID who were referred to our hospital. So what changed in April is most of us have been assigned to new roles. So regardless of our previous activities, whether surgeon, interventionalist, or echocardiographer, we all have been given new tasks to support the new activity of the Brompton Hospital. So we had probably about 80 patients with COVID being managed in our center. Most of them were ventilated, many of them were on ECMO, and obviously these are tasks that not all of us are directly familiar with in terms of management of the equipment and direct management of patients. So we have been assigned to roles mainly towards support the anesthetic team. And this resulted in April in obviously very significant drop of activities, and we were not able, obviously, also to admit patients to the Brompton side for the very reason that the COVID was there, and there were no established pathways to protect patients admitted for routine procedures from COVID. And there were regulations from the NHS side, obviously, not to do that. And luckily, there was the Harefield Centre, which was declared a COVID safe zone. And we were able in April and in May to perform a couple of procedures there of patients referred for urgent management. And these were very successful procedures. And we were able also to continue with this procedure in June, where we have performed a couple of elective procedures as well. So this was associated with a couple of challenges, as it is mainly the Brompton side, which is assigned to percutaneous procedures, and at Harefield, obviously one had to transfer all the equipment required to the other side, and also make sure that all the staff involved at the Harefield side is very much on the case and able to help with procedures. And things changed, obviously, when the number of cases with COVID rapidly declined, and also when our management team established new protocols. This was a game changer. So the new protocols included appropriate testing for COVID prior to admission, 3 days prior to admission. Also making sure that patients, whenever possible, isolate themselves for about 2 weeks prior to admission to make sure that they are not infected. And also the pathways of admission within hospital with establishing corridors for safe transfer of patients so that patients do not intermix. And this was a great success. In August, we were able to go back to about 70% of our volume. And what was the limiting factor was not only the new procedures, but also procedures running smoothly, but also regaining trust of patients. So there was quite a lot of fear. Patients were not entirely convinced that they won't be at risk of contracting COVID. And I'm pleased to confirm that over the last 2 or 3 months, this trust has been regained. And currently, we are going back. We are back at the 100% of expected activity. And I'm very much positive and hopeful that this may continue. So to conclude, we learned quite a lot during this period. We established the safe protocols, and this is, I think, a huge step forward. And also, it will help us to manage with the next coming wave. And I'm very positive with that. And I think we are able also to learn and to improve patient pathways in terms of patient experience, because currently with the improved admin, we are usually able to admit patients on the day of procedure, therefore reducing hospital stay and hopefully running the service more smoothly. So these are the most important points from my talk, and very happy to take any questions. Thank you.
Thank you, Alex. Remarkable work. And I think mirroring other centers' experience, getting back to normal activity has been more challenging than actually converting to a COVID operation in short time. Appreciate it, Alex.
Thank you.
Thank you very much. So continuing our presentations, the next presenter is Dr. Eiling Heng, who is a consultant colleague here with us. And Eiling has also gastrointerventional expertise, but what she will talk to us about is that the technological opportunities no end and the positives out of this. Thank you, Eiling. You're muted at the moment, so unmute yourself, please.
Thank you very much for having me and for the opportunity just to speak over the next 5 minutes very briefly about the technology opportunities for us within adult congenital heart disease during this rather challenging time. Just to briefly mention that they're very clear drivers for increasing the use and application of technology within our current clinical practice. We obviously do this to try and improve patient care with the general increasing role of digital technology throughout all aspects of our life, really. And this is a continuing process that is ever evolving, and this allows us to best utilize potential new treatment technologies and really utilize the power of big data to try and improve the patient journey for our patients. We also recognize that there's increasing role of telemedicine and telehealth, perhaps more conventionally across the other acquired areas of cardiology. And that is certainly something that I think will be brought in the coming near to medium future for us within congenital heart disease. The biggest driver for technological change over the last 6 months for all of us is probably really the travel restrictions and the social distancing that has been imposed by the pandemic in the context of now the second national lockdown. So I'd like to share two of our technological developments, certainly over the last 6 months. Some of our patients logged on at the moment to this webinar may have already experienced this. Necessarily, we've had to convert to virtual clinics over the last 6 months, and that has been a combination of both telephone clinics as well as a video clinic consultation via our Attend Anywhere platform, where we can actually hold patients as such within waiting areas before you are seen by a member of the team. We recognize that this improves patient access, hopefully lessening the overall impact of illness on your daily lives and work. We hope that it has cost and convenience benefits, and it does actually help to optimize time in that it eliminates often quite prolonged travel time periods for our patients who travel from all over the country to be seen at the Royal Brompton Hospital. We recognize that having virtual appointments does minimize the travel carbon footprint, hopefully, and we are working on improving our scheduling process to try and minimize the risk of congestion in an electronic queue that you would otherwise be probably quite used to when sat in outpatients in Fulham Wing. We hope that this helps to overall reduce waiting times, and it's been a very valuable tool and resource for us to obtain multidisciplinary input without the limits of geography. Some examples of this is we have been able to initiate some advanced heart failure and transplant clinic appointments with our colleagues at Newcastle at the Freeman Hospital. And this is certainly a platform that we have used to good effect, we hope, within our preconception counselling high-risk cardiac obstetric clinic as well. The other brief development that I'd like to share with everyone logged onto the webinar is the imminent launch of our clinical app pilot for our patients with adult congenital heart disease. This is a patient-centered initiative that we have worked in combination with a company called Humour to try and help track and monitor health. We hope that this pilot app will serve as a digital personal health companion to our interested patients, and this is really with the overarching view of trying to improve patient education and overall empowerment. This pilot is completely voluntary, and I must caution that it doesn't actually substitute standard clinical care, but we hope that this 6-month pilot that is smartphone-based will be able to provide additional support for our patients in current times. So these are just a couple of screenshots of what the app will look like at the user interface, and it does incorporate symptom and quality of life questionnaires for patients, and you will be able to record a variety of vital signs, including temperature, heart rate, blood pressure, oxygen saturations, and weight. So this will certainly be useful for our cyanotic patients where your oxygen levels are what's normal for you, to be able to track change over time. And equally for our heart failure patients, we're monitoring your daily weight is of increasing clinical relevance as we go along. Given the current pandemic limitations, we hope that actually putting the power to monitor that in the patient's hands, and with us providing input if there are changes and trends that needs clinical attention, will be a useful addition. So it's a slightly free plug for our pilot, which we'll be launching in the coming weeks. And if you are interested, please do drop Dr. Nashat an email on the email address shown on your screen now. So just finally, to briefly mention that there are other technology developments within our field. Certainly over the last 6 months, we have transitioned far more to an electronic request platform across the trust. And this hopes to hopefully help out both outpatient and inpatient pathways to streamline the process and minimize waiting time and system inefficiencies. We are in the process of building a new imaging center. For those of you who may have been to the hospital or past the hospital recently, there is quite a large building site right at our front entrance. And we certainly hope that this will improve access to multimodality imaging when it is up and running. There is also the construction of a state-of-the-art cardiac catheter lab, primarily for congenital and structural intervention, and the new laboratory should give us enhanced capabilities for us to be able to introduce things like virtual reality or augmented reality to try and improve the actual planning and procedural aspects of complex congenital interventions. There isn't really time to go into the role of artificial intelligence for us, which is still very much a research tool, but may come into more broad-stream clinical care in the coming years. And we are all familiar with activity trackers, which are attached to our smartphones, that very much help us keep an eye on our general fitness and activity levels. With that, I thank you and happy to answer any questions subsequently.
Thank you very much, Elaine, for the high-end technological advances taking place, but also the application, because, once this is piloted and refined, it will be something of benefit, not only to the patients that are looked after the Brompton, but far broader reach. And I don't need to remind ourselves and this audience that this is a global disease, congenital heart disease, and there's a global need for it. And again, the challenge with the pandemic and the virus shows how small this world is, and we need to work together. So moving to the last presenter, but not least, is Hajar Habibi, who is our clinical lead on the clinical nurse specialist front. And Hajar joined our team in the midst of the pandemic, and she's been a true force in many of these new exciting developments. And Hajar, in her brief presentation, will talk to us about the patient welfare and well-being. Thank you, Hajar.
Thank you very much for inviting me, and thank you everybody for joining us. I'm just sharing my screen. The key message from the nursing side I just want to kind of take forward is, as a face of a service, we have been in kind of front line getting phone calls and emails from patients. The key thing is for us is to look after our emotional well-being, acknowledging your feeling and taking care of each other. As a ACHT nursing team, we are here and accessible to support ACHT patient and their family. And as each individual team members panel highlighted, it has been and it is an individual kind of patient care, considering patient, family, their social background, patient with learning disability needed advice and support. So we had to take every patient as an individual case. Many patient and staff is experiencing anxiety, and we are here to support and signpost them. There's loads of local resources available, such as IAP, which is improving access to psychology therapy, to access psychology and counseling locally, which is a self-referral throughout the UK. Also, we have our in-house psychology team who's been very supportive to ACHD patient at this stage of first and second wave of COVID specifically. As the kind of previous speaker mentioned, some patient just call us just to say thank you, and that's very kind and kind of very moving. And had a call last week from a patient mentioning that she had a sleeping problem and she used CBT, which is cognitive behavior therapy, online, and that was very helpful to her. And she wanted me to share with other patients, which is very important. Thing we can do to stay mentally and physically active. By being physically active, we can help being as well emotionally active and affect our emotional well-being. Looking for ideas for exercises to do at home. There's loads of resources on NHS website. We also, as a team, have developed 2 leaflets recently, which is on our website regarding ACHD exercise and diet. Spending time enjoying things we enjoy, such as reading and cooking. Some patients called us and saying they taken cooking on board to help them with a healthy diet. Yoga and dancing has been the kind of more highlighted version of kind of indoor activity patient telling us they're doing. The other thing I want to mention, reaching out to family and friends as a support network, and that is a key, not socially distancing, but physically distancing. That's important to get support from other family member or other support network throughout the UK or locally, as well as internationally. Eating healthy and balanced diet, drinking enough water to keep well hydrated, and also exercising regularly and avoiding smoking. Avoiding unhealthy coping strategies such as kind of alcohol, which is in limitation, is good, but not kind of over doing that. And also there's loads of resources available, such as Every Mind Matters and the NHS Mental Health and Wellbeing website, who can kind of give us more information. The 2 charities I'm going to mention kind of nationally, the Somerville Foundation and the British Heart Foundation, they have huge resources for patients, which we direct them to them for advice and information. And also we have the in-house charities such as the Brompton Fountain that can be contacted. Sorry, I'm just going to go to the next page. In summary, I just want to say feeling anxious and stress in such exceptional circumstances is normal, but we are here to help and support you as much as possible to individualize care for each patient. So please approach your local ACHD provider, seek charity support, and keep up to date with the latest guideline. Thank you.
Thank you, Hajar. Succinct and to the point. Maybe all of us can come back on the platform. And we have a good 15 minutes for discussion. So maybe just one of the legitimate concerns out of the questions that we have sent to us has been about shielding and whom to shield patients with moderate, severe congenital heart disease. And perhaps I could ask Natalie in the first instance to comment on this. It is in people's mind. Thank you, Natalie.
Thank you, Michael. And understandably, people are concerned and perhaps confused with various mixed messages that have come out in the media about what patients with underlying health conditions should or shouldn't be doing. I think actually Gerhardt's presentation was very helpful in emphasising the approach that most, probably all clinicians now have in ACHD, which is the approach to the degree of self-isolation that people need to undertake. Is very much an individualised approach. I mentioned the national meetings that have gone over the last 6 months with the various clinical groups getting together and discussing how to tackle COVID. And one of the main topics, particularly in the first 3 months, was how to advise patients on who should shield and not shield, who just needed to take enhanced precautions but not undergo the full shielding. And as you can imagine, as I'm sure many of the patient groups may have come across, if you ask enough doctors the same questions, you'll get numerous answers. And the national group was unable to come up with a unifying list of patients who should or shouldn't shield. And as Gerhard's pointed out in his presentation, that really depends on many other factors other than just somebody's initial underlying diagnosis. So the advice on shielding or protecting yourself, the levels to which you need to do that really need to be discussed with your individual ACHD teams who know you well and will be most up to date with the progress of your other comorbidities as well as your congenital heart disease. The only thing I'd just point out there, though, along with the shielding, is because I don't think it's been mentioned as yet, is just the additional advice as well as shielding or taking the appropriate precautions regarding good hand hygiene and social distancing, is the importance of attending your medical appointments where you do have them. Making sure that if you're not sure if they're absolutely essential, that you phone your teams to check with them whether or not your teams feel that you really need to attend the appointments if you're concerned. And the final point I would make is that we are still encouraging all of our patients to have their annual flu vaccination. And I think there has been some difficulty in getting access to that through patients' GP surgeries at times, but we would very much encourage you to continue to try and get your flu vaccination done as soon as possible.
Thanks a lot, Natalie. Important points, all of them. There's a question from, I guess, one of our patients in the audience who has Fontan circulation. So this is the serious end of the spectrum of congenital heart disease in their 40s, about shilting. And I don't have anything else to add to what you said, Natalie. But again, to make the point and reinforce that what can we make out of this period of 6 months of challenge and adversity? And what can a Fontan patient do to protect themselves from a bad outcome if they had an infection, including COVID? And in a very simplistic way, the best way of arming themselves is to have the best lifestyle possible. And in fact, it's not just through the pandemic. You've heard this, me talking about slim and athletic, which is an extreme position, but so relevant for all of us, particularly for the patients. So somebody who is on good diet, is not obese, does not have diabetes, are physically active with good skeletal muscle, this patient with a Fontan or not are better armed towards a poor outcome. I think on the same issue of shielding, Hajar, out of the many questions received, there's a patient, a pregnant patient under our care. Could you please tell us a bit about her concerns and what advice you would give?
So we just recently saw a 31-year-old lady who is a TGA, transposition of great artery, and she's 12 weeks pregnant. She came to our joint clinic with obstetric and cardiac team for review. Obviously, she's got background of anxiety, and she's a primary school teacher, and the majority of her phone calls and emails coming from kind of key workers, especially teachers. So she kind of obviously cannot do social distancing with kind of 4 to 5 year olds, in a big class of 30 children. So she herself didn't want to social distance despite the message you give. So the key message everybody kind of highlighted today is you need to is individualize it to that patient. What is suitable for her and her lifestyle. She said if she starts shielding from now, she would be more anxious sitting at home, considering she's only 12 weeks pregnant at the moment. So she wants to continue, and obviously we support her and review her in 4 weeks when she comes for review to see how she feels herself. But when we advise patient, we go through each individual cases, considering, as Gerhard said, the social background, their other comorbidities, if they have any other issues apart from their heart. And in her case, which was interesting, she says she does not want to shield because she would be more anxious sitting at home. So from nursing point of view, we go to nursing school and saying you have to have holistic approach, and I think that's the example of holistic approach, putting patient at the center, and we make the joint decision together that is suitable for that patient. So that's something we've been doing from the beginning of pandemic, from first wave of it. Patient calling us, we're trying to individualize the care according to each patient. It hasn't been easy, and there's no right or wrong answer sometimes, but we come to conclusion together as a team with the patient, with the family, with their background, to make a unified decision that is suitable for that specific family. Thank you.
Thank you, Hajar. I think I've experienced the limited anecdotal experience from here would also support such a thing. And it's, in fact, Heba Nashat should be on this panel, but she's been collating data from our practice of more than 10,000 adults with congenital heart disease this year. Only a very small number of them had confirmed or suspected COVID, and with good outcome even amongst them, with the exception of 2 patients who had pulmonary arterial hypertension. So systemic RVs, patients who are otherwise well with no risk factors, can weather this well. I was going to come to Yiling first and then to Gerhard with 2 questions. Yiling, give us some wisdom. Singapore has done extremely well. What is that works out so well for them that you can learn from? And then for Gerhard, any prediction of when do you think that we'll have a vaccine for COVID? Yiling first.
Thank you, Prof. I'm not sure how qualified I am to comment on Singapore, but certainly I think the differences have been a far stricter national lockdown that was enforced from the word go. I think certainly across Europe, we were perhaps a bit more reluctant to do that, and that's had a trickle-on effect. I think because the geography and size of Singapore is small as well, contact tracing has been far more aggressive and a bit more successful than it is with all the multitude of air travel channels across Europe that we have here. I think testing was also taken up very aggressively early on in Singapore, and I think there are lessons we all learn from each country in terms of what we could do better as we continue along the lines of the pandemic, which certainly is, we haven't seen the back off yet, I think is the general feeling.
Thank you, Yiling. And just as a relationship to this, to say that clearly this virus has been around for much longer than we thought of. Probably in Singapore they were aware of it. And it transpires that patients of ours have had COVID infection on clinical grounds back in December or January. So this is another reason for putting this to that large forum, that this time around the wave is not going to be the same because we're better prepared. There is some cross-immunity. There is maybe some other factors operating. We're better prepared for it. And what we're seeing in terms of numbers is reported cases with more testing. Albeit, there is obviously still morbidity and mortality, particularly in high-risk groups. And somehow, at some stage, we need to strike a balance between more measures versus getting life to continue, and the economy and the impact of it. I don't want to sound political, but we're coming close to that point. Gerhard, what do you think about vaccination?
Speculative, of course. I'm not heavily involved in this. I think we all expect to have some vaccines around within the next few weeks, few months. The question will be how safe they will be and how efficient they will be, and then we will see how this works out. But I'm sure long term we will have to get used to having routine vaccinations for COVID as we have for the common sort of flu, influenza disease, and probably will become part of our life. But as this is at this stage, I guess it's speculative, and we'll have to wait for the results of the clinical trials.
Thank you, Gerhard. There is a question from the audience. I think that comes from a professional, either a doctor or a nurse. asking, and it's a question really for Alex. Alex needed to go back to the cath lab. How are you managing 100% of activity with a reduced number of beds? I think the answer to this is a better use of resources and people going out on a limb, coming together through this crisis to provide work out of hours, go to intensive care. And I have to say a big thank you to everybody for keeping the operation going and providing for the patients. And then the second question from the same person, have you caught up on your backlog of patients needing procedures? And the answer is not yet. So we are delighted and have to reassure our patients that we're not just a COVID center now, we have capacity to continue with the work needed. And maybe if there are any comments from the panel, I think we've got a minute or two, or any questions that you want to address.
I'll just come back to that last point, Michael, about dealing with the backlog. And around the country, most centres are getting back towards their usual levels of activity in terms of surgical and interventional procedures. But of course, that doesn't, what we really need to be doing is working at 110, 120% of our previous capacity to get through the backlog in a timely manner to get back to our usual levels of patients waiting for procedures. That I don't think will be possible in most centres, at least not in a sustainable way. But just to reassure people, what everybody is doing is regularly looking at their waiting lists and reprioritising patients who are on those waiting lists to make sure that those people that need their procedures soonest in terms of clinical urgency have their procedures and their dates booked, but equally making sure that those patients who have much more routine procedures are not forgotten about. And so it is a process where we are continually reviewing what's on waiting lists, and in fact nationally we're all submitting data at the moment as well, because NHSE are interested and want to know what is happening with waiting lists so that they can help us with resources or planning if needed in the future, if it looks like everybody's waiting list is just continually growing rather than gradually reducing back towards normal levels.
Thank you, Natalie, and thank you all for your participation, excellent presentations. Thank you all the participants, the large audience. Thank you Live Media for being with us, the Samuel Foundation. Virus is not going to be here forever, and there is light at the end of the tunnel. We're here for you and to continue to support in any way possible until we get the vaccine, which is going to take some time. There are certainly things that we can do to ourselves, for ourselves, to help. And back to what I was saying earlier on, this mantra, slim and athletic, it does help. Thank you very much. Thank you.